This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1222, recorded on May 29th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What you got on the tie, Daniel?
So these are waterborne pathogens. There's a whole bunch of different things on there, like gram-negative rods, coccidia, all the stuff you can get from the water. Not all of it.
Too bad. Water is so important, and it can really hurt you. Right?
Kind of crazy, right?
Yeah.
All right, we got a lot to cover, and I'm expecting a little emotion from you there, Vince. And there's been some upsetting things going on.
Some people write and they say for me to calm down, but I'm not going to calm down. I'm
Don't
Italian.
calm down,
Daniel. I'm Italian. It's in my, whatever it is. I inherited it. My father was a very excitable man.
It's funny you mentioned that. Recently, when I was on service at Columbia, there was a Columbia emeritus professor that we were taking care of. And I joked that his PhD work was all on the fact that Italians speak with their hands. He discovered that, apparently. No, but he studied all the nonverbal aspects of communication. And there really is a lot, right? They're trying to get AI to communicate with dolphins, and so much of their language is body position. You see this with dogs and Italians and dolphins.
I do use my hands a lot. I'm always waving.
Yeah, if you don't have your hands, if people aren't watching this on YouTube, they're missing half the show. So, all right.
So, Daniel, it's funny because sometimes, like you and I on the video are next to each other, but David, our editor, sometimes she says, I can't see your hands, so I'm going to give you the whole screen because your hands are waving and they're outside the...
Well, apparently I was listening to the podcast. When I come to the studio, the way the last shot was, that one just right on me, apparently made me look quite attractive. So I've got to start coming to the studio to get the glamour shots.
You can come anytime. We have your coat here waiting for you.
It's a challenge on Thursdays, right? Because right after this, I rush sailing out and I go race sailboats. So
it's not possible.
All right. So I will start off with my quotation. The most revolutionary thing one can do is always to proclaim loudly what is happening. And that's Rosa Luxemburg. And I'll encourage people to look Rosa up and check out some of her quotations. But I think that's what we're doing. We're being revolutionary here in that we're actually proclaiming loudly what is happening. And in that, we have our new section, the attack on science. I was wondering if there'd be any material for this week, but we were on May 27th, 2025. This will go down in history. RFK Jr. announced, all by his lonesome, with a couple fellows on each side, that the COVID vaccine for healthy children and pregnant women was removed from the CDC Gov recommended immunization schedule. So can he do that? Can this one person just get up there and just say that? Well, a little background here. So the CD estimates that only 13% of eligible children and only 14.4% of eligible pregnant women receive the latest version of the coronavirus vaccine. So we're doing great to begin with. Now, I will point out this move, if it really is a move, bypassed the traditional process. So normally what happens is a vaccine is approved or authorized by the FDA, right? So they get the safety, they get the efficacy data, and it gets submitted. They usually ask ahead of time, so this is what we need to see for licensure, for approval. The FDA then approves it. And then the CDC's Independent Vaccine Advisory Panel holds hearings to determine who should receive the vaccine, when, how often. This is updated. It's a committee. They've got this panel, the Advisory Committee on Immunization Practices. We know some of those folks. A lot of us like to watch the meeting. It's open to the public. There's public comments. At the end of the day, there's a voting decision. What are we going to recommend? And then its recommendations go to the CDC director, once the CDC director signs off, then the recommendations become official policy. And this is important because once you have official policy, and this is always traditionally how it's been done, then the insurance companies are required to cover the vaccines with no out-of-pocket cost to the consumers. Now, this may be the first time an HHA secretary just overruled and just unilaterally by themselves just said, I've decided this is the new policy.
So, Daniel, this is an HHS secretary who's a lawyer and a politician, has no science background. And the committee, the CDC Advisory Committee, is full of professional people with experience. Now, tell me how that makes sense, Daniel?
So it makes no sense. And it's one of those things where there are certain political things in place, right? And so my understanding is the HHS secretary can do this, can just say by themselves, I'm a political appointee. I made it through Congress. I've been appointed. I'm going to make up my own rules. I don't think people realize that because I don't think this position, the power of that position had ever been abused like this before. Normally, as we discuss, you have an FDA and they're responsible for licensing safe, effective products. And then we have a second layer where we have experts give guidance on who should or should not go ahead with this. And then it's not a mandate at any point. There's no mandate here. Then once those recommendations are out there, then doctors and patients can have these conversations. Really what you're doing here, what he's doing here, is he's really giving the insurance companies an out. He's all by himself saying, this is going to be the new thing. You insurance companies, you don't have to pay for it anymore. If someone wants this, if someone has a conversation with their healthcare provider, nope, you're going to have to fork over money out of pocket. This is going to be off-label. This is really an abuse of power by someone with, as you pointed out, no medical training. This guy didn't go to medical school. He didn't take an oath.
So the effect of this is that your insurance will not pay, but you can still get the vaccine if you pay for yourself. If you go to a CVS, will they give it to you even though you're not over 65? So
there's a lot that's still up in the air that we don't know. I mean, one thing I went to the CDC site to see is this really true? Because he tweets this out basically, sends this out on social media. The CDC site was last updated May 12th. It's still what it was. Still the recommendations are there. When does this go into effect? Does it really go into effect? Is he just sort of announcing this? When he says it's been removed, effective when? And that's the other question. If it's now no longer recommended, is this going to somehow impact the licensing, right? And we talked about this last week. If they update the vaccines, right now they're licensed by the FDA for all these people. So is this somehow going to circle back to FDA? Is it going to be off-label when you go to get your vaccine? Is someone going to be there, checking, making sure that you qualify with these new recommendations? And we're also going to talk a lot, and I'm going to jump into this right now, what's the data? Does this make sense, right? And so, who are the two groups of people? So one, taking it away from the children, and also taking it away from pregnant women, also taking it away from newborns, right? So just wanted to share some of the data. So I just want to remind everyone, because so many people say this, 1 million adults died, but not so many kids. Well, what do we mean by not so many kids? So a reminder that COVID-19 quickly became the 7th leading cause of death for 1 to 17-year-olds in the first couple of years of the pandemic. In the first couple of years of the pandemic, it killed an estimated 1,086 children. That total is now up to over 2,145. And I have some data here. I'll leave in links. We saw over 1,000 little children, 0 to 4 years of age, 1,112. That's the total death count. 5 to 11, we saw almost 400. 12 to 17, we saw over 600, 639. So we have so far seen over 2,000 children. So I just want to sort of ask this, when does it become okay to have 2,000 vaccine preventable illnesses?
No, it never does, clearly.
I mean, I hope never. I hope I'm not living in a country that says, oh, that's okay. And so I also pulled in Paul Offit's Substack. I got his Substack, and I'm going to send in a link to it. Couple of the things that he points out here, and this is actually data. I'll even a link from the Advisory Committee on Immunization Practices, and he points out just this past year, right? Everyone's talking about, oh, it's become mild, it's not a big deal, COVID's not a big deal. Well, the data we saw presented just for the last year, 165,000 people were hospitalized because of COVID. 40,000 people died. About more than 1 in 25 of those hospitalizations were in children. Just in this last year, 150 children died from COVID. Most of those were under 4. The other thing I want to point out, and this is his issue, oh, healthy kids don't need the vaccine. About half of the children less than 4 who were hospitalized or died from COVID were otherwise healthy before they ended up in the hospital. We did not know there was some susceptibility there. About 1 in 5 of those children ended up in the ICU, even higher when you look at the youngest of them. And this is the big one. More than 90% of the children hospitalized or died from COVID, not vaccinated. These are vaccine-preventable hospitalizations, vaccine-preventable deaths, and a disproportionate number of the children who died were less than 6 months of age, right? So the only way those children get protected is when mom gets a vaccine during that last trimester and then protects those babies.
So these data are available to the HHS secretary. Why weren't they consulted in making his decision?
Well, I think if you or other of our listeners have actually read the Make America Healthy Again 69-page report, rather than actually looking at real data, they actually they like to quote stuff that really is confirmation bias to their agenda. Studies that either didn't happen or were seriously flawed. Yeah, very, very upsetting. And I have to say it's interesting. So I read some of the mainstream media coverage, right? So yeah, don't worry, we're gonna upset them as well. So a recent New York Times article, and so this is I want to sort of read a little bit of this New York Times article. I like the New York Times reporters. I obviously read your paper, so take that with whatever. Children who have COVID are generally at low risk of hospitalization. About 234,000 children in the U.S. were hospitalized. Children and teenagers still accounted for about 4% of hospitalizations. So 1 in every 25 people hospitalized for COVID were children. Nothing to see here. This is low risk. This is rare. They then go on to write, after they've sort of minimized this, pediatric COVID deaths are rare. Provisional data from the CDC shows over 1,800 children in the U.S. have died of COVID. So why do you word it that way? Yes. Why do you say pediatric COVID deaths are rare? That's what they're going to quote. Why don't you point out that somewhere around 2,000 children have died of COVID? And as we pointed out, these are mostly preventable deaths. When did it become okay? When is it rare when you have 2,000 children die? Now, at least they remind people in this article that CDC data found that half of the children who are hospitalized because of COVID had no underlying medical conditions. And what about post-COVID conditions or long COVID? Even at the lower end, we're seeing about 1% or roughly 1 million children have ended up with long COVID.
Yes, that's a lot of kids. And as we said, vaccination can reduce that risk, right?
Yeah, I mean, it really can. So, but unfortunately, where it's becoming easier and easier to get out of those vaccines. So we hear about a bill approved by Texas lawmakers. It's sitting there for the Republican Governor Greg Abbott to potentially sign. Really would make it significantly easier for patients to enroll their children in school without standard vaccinations. And so this bill streamlines an already legal exemption process, allows you to go online, download this form. You don't have to deal with the state health officials. Basically, you get this form, and then you could just object out. Say, you know what, I'm just not into it. I have reasons of conscience that I'm going to not protect my child. I'm also not going to protect my community, and I'm going to allow all these infections to occur.
Reasons of conscience? Religious beliefs? No, that's false. So, Daniel, if, let's say, we make vaccination voluntary, you can get vaccinated if you want. How many people in the U.S., what fraction of the population would elect not to vaccinate themselves or their kids?
So right now, I think that number is going to be probably about 20%.
Wow.
Yeah, it's really a huge problem. I was talking to my wife about this while we were running. See, we're athletic and exercising. Every time I run, I make sure to throw that in conversation. Maybe it doesn't happen as often as it should, but we're starting to see this separation in our country. Right, there's certain parts of our country, life expectancy is in the 80s, really high vaccination rates. Other parts of the U.S., I hate to say, we have vaccination rates under 90%. We have average life expectancy down in the 60s. Huge differences. We're already seeing it in education, in economics. We're really kind of ending up with these two parts of our country. We have people who are really falling victim to a lot of misinformation. And then we have sort of higher education information people. It's not fair that people are taking advantage of these individuals. And, we saw in Texas, we had this little girl die, and the parents, felt like they made the right decision not to protect their daughter and to have this little girl die.
Yeah, I mean, if it does hit 20%, then this is going to be very bad.
Yeah, no, it's a disaster. And again, there was a certain point in time when these diseases were right there in front of us, and we were seeing apparently 2,000 children dying of COVID. It's not enough. People are upset that we were protecting, that there weren't more children dying of COVID. So, it's crazy to me. What is that number? How many children need to die before people say, oh my gosh, actually, it is worth vaccinating and preventing these children from dying?
I mean, dying, but 1 million kids getting post acute sequelae of COVID. That's a lot of kids.
It really is. And it's really tough because I think a lot of these kids, when they're seeing the pediatricians, they're seeing family practice doctors, they're seeing primary care doctors. They're really kind of a lot of it as well. You should be better by now. Give it time. I mean, I've taken care of and been involved in advising the care of some of these individuals. It's devastating. These kids are missing educational opportunities. They're missing a lot of social opportunities. They're suffering. This is really, and they never calculate this. They look at the deaths, 2,000 deaths. Apparently that doesn't bother them. Thousands of hospitalizations. Apparently that's acceptable. But all the kids that are suffering with the post-COVID conditions, not even being factored in. Well, one of the other things I want to put right up front. I don't know why I put it up front. Let's see. Maybe as I read it, I'll remember why. But this is this article, Cardiac Events in Adults Hospitalized for Respiratory Syncytial Virus versus COVID or Influenza, published in JAMA Network Open. And so I thought this one was worth discussing. And maybe as we go through it, I'll figure out why. But this is a cross-sectional study compared 32,960 hospitalizations for RSV with hospitalizations for influenza or the Omicron XBB JN1 COVID-19. Now, 10.9% of unvaccinated adults hospitalized for RSV had an acute cardiovascular event, right? So more than 1 in 10. Significantly higher odds of cardiac events were observed in patients hospitalized for RSV versus those hospitalized for COVID-19 who had received boosters or those hospitalized for influenza after vaccination. And these results come from a population-based cross-sectional study conducted before RSV vaccination rollout in Singapore. They assessed all adults hospitalized for RSV or flu or COVID, total of 32,960 respiratory viral infections. RVI hospitalizations were included, a couple thousand for RSV, 14,000 for flu, 16,000 for COVID. Of the individuals hospitalized for RSV, as I pointed out, 10.9% had an acute cardiovascular event, higher odds of any acute cardiovascular event, 1.31, as well as other individual cardiac events were observed in the RSV hospitalization versus the boosted COVID-19. Similarly, higher odds of any acute cardiac event, as well as dysrhythmias or heart failure, were observed in patients hospitalized for RSV versus unboosted COVID-19. So I guess the reason I wanted to bring this up is a lot of times people get upset with me because I will talk about all-cause mortality when I'm talking about all the negative things that happen with COVID. And I want to just say, this death within 1 or 2 weeks. But as we've pointed out a lot of times, is these folks may make it through that first week or two. They may also get into the hospital and then they die of a heart attack, or they have a stroke or another sequelae. And as I'm trying to point out here, is it's all tied. That person was going along, doing just fine. They get RSV, then they have a heart attack, then they have a rhythm disturbance, then they have a stroke. And the same thing with COVID. See, you can't just say, oh, that wasn't a COVID death. That wasn't a hypoxemia on the ventilator. And for a lot of us, having a heart attack and developing heart failure, having a stroke and all that comes with that, these are horrible things. So just want to point that out.
And then, as you have said before, even after discharge, a higher rate of cardiac problems in people who have been infected.
Yeah, I think we talked about a study a couple weeks back where they, 10% of people, this was a COVID-19, 10% of people get readmitted. If you follow them out to 60 days, 8 or 9% of them are dead.
Yep.
You can't just look in the first week or two. You can't just say, oh, but when I think of a COVID death, I define it in this very narrow window. All right, bird flu. No one's talking about bird flu. We'll talk even a little more next week, but just to give people a little bit of an update here, over 13,000 wild birds detected, 51 jurisdictions with bird flu in the wild birds, 171 million poultry affected, 51 jurisdictions with outbreaks, ongoing outbreaks in poultry. We're not hearing about this. Over 1,000 dairy herds affected, 17 states with outbreaks in dairy cows. So you may not be hearing about it, but it is still it's still ongoing. And what about measles? That's over, right, Vincent? They've got that all under control. No, unfortunately not. We need to get like a really old doc on board who remembers the sort of a seasonality to measles cases, because I'm kind of hoping there's some sort of break here as we get into summer. But as of the last update, we get updates every Friday. We're up to over 1,000 confirmed measles cases, 31 jurisdictions, so most of our country. And again, this is an issue. 96% of these folks do not have confirmed vaccination, so unvaccinated or no evidence that they were vaccinated. And again, 12% are ending up in the hospital. So we've got over 100 people that ended up in the hospital. A little worse in Canada, 2,515 measles cases up there. You can see sort of a clustering there in Ontario, if you know your Canadian provinces.
Paul Offit says measles typically ends in May.
Okay.
So we're at the end of May, and we're still ongoing.
All right. So I'm hoping it starts to decrease a little. I'm hoping that there's some seasonal break that we get here.
Well, then RFK Jr. will claim credit for that,
Okay. So when it gets warm in July, is he going to claim credit for that too? And cold in January? All right. I think I know some other politician who claimed, yeah. All right. I just did a talk for the New Hampshire pediatricians on vaccine preventable diseases yesterday. They're not doing well with measles vaccines up there in New Hampshire. I was looking at this nice, like above 95%, except for this outlier, less than 90%, which was New Hampshire. But just reminding people, if you might be seeing measles, just remember the 3 C's and the 4 D's of measles. So the kid comes in, cough, coryza. What is that? That's really red, inflamed, runny nose. Conjunctivitis, right? That's the red eyes. You don't really know what it is, but then you get 4 days of fever, and then you get the rash, right? So the 4 days, the 4 D's of fever, the 3 C's. And then the other way you can use those 4 D's is it's been suggested that you're most contagious 4 days before the onset of rash and the first 4 days of the rash. So folks here are contagious for quite a period of time, and they're contagious before you see that rash, before you realize it's measles in many cases, and even after you realize it's measles. So I will continue to leave in the recommendations for the MMR vaccines, the safety issues, facts and myths about measles. That was a question that came up. where do I go to get good information about the MMR vaccine? Basically pointing out the MMR vaccine does not cause mercury. There is a comment, I guess, listen to the other episodes. Has there ever been a death related to the MMR vaccine? Maybe there was a consanguineous child who died after.
Yeah, so a child with a inborn error in interferon pathway died of measles, disseminated measles after getting vaccination. That's the only case I know of.
Yeah, I'll leave in a link to that JEM article, Journal of Experimental Medicine article. All right. Flu, things seem like they're sort of coming down, but I will point we are up to 231 children died this flu season. We had another 4 influenza-associated deaths reported this past week. So over 200 children died of flu. I want to point out 90% of those deaths occurred in children who were not vaccinated. These are over 200 children we lost this winter from a vaccine-preventable illness.
And these children were not very, very sick, as RFK Jr. would probably claim.
He's got this idea in his head. It's not true, but he says it, that these children were like at the edge of a cliff. They were just about to die anyway, and flu pushed them off. That's not true. The majority of these kids were completely fine before they got the flu. I remember a number of years back when we were living out in Fort Collins, and 2 teenagers died of flu. One of them had asthma. Oh my gosh, I guess they were going to die anyway because they have asthma. That's not true. Kids with asthma don't just fall. They don't just drop. And the other was completely healthy. And that's what we're seeing is, half of the kids are completely fine. And then 48 hours later, they're not with us anymore. So, when you think about the fact that we used to vaccinate the majority of our children, we now vaccinate the minority of our children. We've lost that. And we don't need to have 200 children dying of flu. Okay. All right. RSV. Also, things are a little bit low there, which is good. Just, reminder. And I think, things were a little better. I was actually talking to one of the pediatricians before sort of did my talk yesterday about, this was the first year where they weren't sort of struggling to keep up with the oxygen requirements, struggling to have enough oxygen and supplies, high flow, et cetera, for the kids. So the nirsevimab for the little kids had a nice system up there where they get their monoclonal antibody at that first visit after they're born. So Beyfortus or nirsevimab. And then there also is the Abrysvo for women who are in that last trimester, the 32 to the end of the 36th week. It is interesting, just a little comment there from the CDC is that, this is only for a woman's first pregnancy. Sort of seeing some data why that's true. So subsequent ones, you're really going to be looking at the nirsevimab protecting the little kids. But really great data there on keeping the kids out of the hospital, keeping them from having all that trauma and inflammation to the lungs, and preventing deaths. Okay, the article, Respiratory Syncytial Virus, an under-recognized healthcare-associated infection, was published in the journal Infection Control and Hospital Epidemiology. I wanted to share this because, one of the hospitals I go to, they recognize that RSV is actually, it's a germ. You can transmit it to others. You can get them sick and they can die. One of the other healthcare systems, they don't really treat it as a infectious germ. And it's like, we never see RSV from patient to patient. So I'm not sure where that all came from, but here's some data that is going to really challenge that. So here we go. Surveillance data from RSVNet were used to evaluate the population level burden of healthcare-associated RSV. The incidence of healthcare-associated RSV was determined using the traditional definition. So here's this positive RSV test after hospital day 3. And now they're going to look at, in addition to often unrecognized cases associated with recent post-acute care facility admission or recent acute care hospitalization for a non-RSV illness in the preceding 7 days, right? So you use this first one, they show up, they're negative, and then they got a positive test on day 3. But what about the person who just got discharged and now they're sick and now they've got RSV, right? And they were in the hospital the few days before this happened. What about them? So among the 900 laboratory-confirmed RSV-related hospitalization, 4.6% had the traditionally defined healthcare-associated RSV. Now, when they included patients with a positive RSV test obtained in the first 3 days of hospitalization and who were either transferred to the hospital directly from a post-acute care facility or who were recently discharged for a non-RSV illness in the preceding 7 days, they identified an additional 95 cases, so an additional 10% of all RSV-related hospitalizations. So more than double what they were picking up with this other sort of odd, stringent definition. So yeah, people are going to the hospital. They don't have RSV. They're coming out, and now they have RSV. Where did that come from? How did that happen? What, did they have wet hair in the hospital and bad character? No, it's germ theory. All right.
It's not miasma, Daniel?
Maybe there's bad air in that hospital. Maybe it's bad air full of germs, full of microbes. All right. COVID. So let's jump straight to our multicolored curve. We're kind of down there in the low, very low in most of the country. I'm seeing a couple areas where maybe we're starting to see that it's almost time for our summer surge, right? Should we do a betting pool again, Vincent? What do you say? Are we going to get a summer surge?
No summer surge. No summer surge.
I'm voting for a summer surge. All around the world, we are starting to see a rise. So I think that we're in this little bit of a lull. And how long are we going to get a little bit? No, I think we're just about ready. I think we're going to start seeing a climb so we're end of May now. So June, July, we're going to probably get a peak, I think, in July.
So many countries are experiencing surges, right? China and India and others at the time. So maybe it's the summer surge over there already.
I think they're already getting a summer surge. I actually heard from one of my colleagues in Taiwan, and they're getting quite concerned because they're actually the pediatric wards are completely full. So they're completely full. And, you and I sort of see this seasonal pattern. We see the impacts of season and weather and behavior. But then there's a whole school of folks that are really worried about the variants, Vincent. It's all about the variants.
I don't think it's all about the variants. I think it's just the seasonality is really weird for this virus. It shouldn't be winter and summer. That doesn't make any sense. Something unusual is going on. We said before maybe it's population immunity, but I think now a lot of people are immune, so that is really not explaining it.
Yeah. Interesting thing is what they're, the people that are focused on the virological characteristics of SARS-CoV-2 have started to have concerns about the variant that they're seeing over there is now this NB.1.8.1. And I'm actually going to leave in a link to a medRxiv article. Actually has a nice, what do you call these? Trees, basically, genomic trees.
Phylogenetic trees, yeah.
Yeah, phylogenetic trees. I couldn't remember that word, phylogenetic tree.
So Daniel, it would be interesting to know in all these surges that are happening elsewhere, how many are serious disease and how many are just infections, mild infections that they're picking up. Because, I don't think the variant, it may evade immunity and you may get infected, but then your T cells are going to protect you from severe disease if you're under 65, say.
Yeah, I think that would be interesting to know also when I, am told that the pediatric wards are filling up. Are these novids, right? These are really young kids that have never seen it before. Is that what's going on? The interesting thing when I look at the phylogenetic tree here is there just were these discussions last time about which JN1 lineage are we going to target with the new vaccines, right? Because they want to try to target to get the best antibodies because T cells are going to be fine. I'm sure they really care. But you can really see there was a lot of talk about this LP.8.1.1, but the NB 181, I'm going to call it that for ease, is really off on the other side of the phylogenetic tree. So if this really rises to prominence, they may have kind of gone down and missed the variant thereafter. I would love if they actually, maybe this is something that'll be forced upon them, compare the current one, say we've got this JN1, we've got this KP3 out there. Let's make a third vaccine and let's compare. Does it really make a difference? Do you need an NB.181? Do you need an LP811? Does it really matter? Do we really have to keep chasing these variants? So
That has always been the question, Daniel.
we should do the experiment. Imagine that. Imagine admitting we don't know and doing the experiment, because NB181 is actually it's being detected here in the U.S. So we'll have to see what the variant's going to be, and it'd be nice to know, does it really matter? Because with what we're seeing now, if they're going to actually require new licensing, if that's going to restrict access for people, then it becomes a question. Like, if you make a recommendation that may or may not make a difference, are we going to lose the ability to actually get that to people? Because, vaccines don't prevent illness, vaccinations do. So if you got vaccines sitting in a warehouse, nobody's benefiting from that.
Well, also, Daniel, if you're under 65, it doesn't matter what variant you have, you're not going to be able to get the vaccine.
That's what I worry about. Yep. All right, moving forward, ventilation transmission. What have we got here? The article, Isolating the Burden of Transmission-Based Precautions for COVID-19, Walk-in Clinic-Based Healthcare Personnel Perspectives, published in the journal Infection Control and Hospital Epidemiology. So this is really like, what do people feel? What do healthcare providers feel about all this personal protective equipment and the guidance on what they're supposed to be doing? So here they go ahead and they've got this pilot that was conducted in WICs, walk-in clinics. I like that, to evaluate healthcare provider perspectives on the benefits and the challenges, trying to figure out who do you need to worry about, who might have COVID-19 when you check them in, for whom should you be wearing these personal protective equipment. And they really, it's a survey. They're using Epic. It's triggering a flag. It's telling you whether or not you should be donning and doffing this stuff. And then they ask the healthcare providers, what about time required for patient encounters? This is going to add a lot of time. You're gonna get, basically, most people say, yeah, I got to put all that stuff on and off. It's going to take me extra time. About 70% of them thought it was going to take extra time. I'm not sure who thought it wasn't going to take extra time. How many people thought that this was really going to be a burden? And that was, again, most people. Now, easy to identify patients requiring isolation. They've got this nice Epic system. So yeah, that was easy to do. Most people knew which PPE to use. So just sort of basically pointing out that when we put these things in place, there's a certain impact to doing that.
So Daniel, the last one is very interesting. I felt more protected from potential infectious exposures while wearing PPE. Most people neither agree nor disagree with that.
Yeah, only 19% strongly agreed.
Yeah, that's interesting. I wonder why.
These are healthcare providers, right? These are healthcare providers going in. It'd be interesting to break that down. Are these like physicians? Are they nurses' aides? Like who didn't really want to wear proper protective equipment when you go in a room with someone that might have, something that's going to make you sick? Mm-hmm. But this is my favorite. This next one is my favorite. This one came up this last weekend. So this last weekend, I left town. I went upstate with the family, and I stayed in this old, I'm sure I'm going to pronounce this wrong, but a Hitterite or Hutterite church. Mm. And so the Hitterites were a group that, like all the Puritans, right, that came to America, right? They were like kicked out of other countries because they were annoying everyone else. And so this communal group that came to this part of upstate New York, and it was sort of a church. It was a religious space, but they also lived there. And it was this huge cold stone building that had been converted into an Airbnb. And I'm there with my wife and my son and my daughter Daisy and some friends. And my mom had been sick, and Barnaby was sick, and Barnaby was coughing, and then Jessica was coughing, and then Daisy was coughing. I'm fine, by the way. But so Daisy's boyfriend was there. My daughter has horrible coughing etiquette. She just coughs, like plume goes out. And her boyfriend, John Scott, was trying to work on coughing etiquette. And just, lo and behold, the article, A Pilot Study of Coughing into the Shirt to Disrupt Respiratory Pathogen Transmission, was published in the International Journal of Emergency Medicine. For those of you watching, Vincent is preparing himself to cough with his shirt up over his nose. Now, we read, scientific evidence is lacking for the respiratory etiquette maneuver of coughing in the elbow. This pilot study introduces and evaluates a novel maneuver, coughing into the shirt, comparing effectiveness of containing respiratory plumes, I like the visual there, to existing respiratory etiquette strategies. So in this open bench, observational respiratory etiquette pilot study, 5 healthcare workers performed 4 respiratory etiquette maneuvers, including unobstructed, we'll call that the daisy cough, into the elbow, into a mask, and then finally into the shirt. And observational data for the cough maximal plume area and area calculation were collected using slow motion video recording. And you can actually, they've got this, you can take a look, and they've got this guy, I don't know why his eyes, so you can't see who's doing it, but they've got this one guy unobstructed coughing, and you can see this huge plume. You can see the elbow with kind of the similar plume size, but sort of directed downward, coughing into the mask. It's kind of nice. It sort of shoots out the back and, up the head. And then you've got the shirt one where most of it's contained, maybe a little bit sort of squirts out. Maybe you should tuck that shirt in or something. But all respiratory etiquette maneuvers significantly reduce the maximal plume area. And comparing the maximal plume area of the unobstructed maneuver to the in the shirt maneuver, they found a 95.4% decrease for the into the shirt respiratory etiquette maneuver.
Okay, but not everybody has a shirt that you can pull up over your face, okay?
Well, that's what I was realizing. Like, I'm sort of trying to get the bow tie on. I'm in trouble here.
No, and many women can't do this, and so it's just not going to work.
Well, I guess if you can't cough into the shirt, the mask tends to work pretty well.
Yes, according to these pictures.
Yeah.
The mask.
Well, they have this nice figure 3, where they actually quantify for the 5 different participants, right?
Yeah.
The other thing is certain people they're just nothing but trouble. Like you sort of want to identify like who you're going to hang out, who's like this maximal plume area, like number 4. So participant number 4, they've got this scale of maximal plume area. This one person, I want to say fellow because it's a guy, right? The guy's like coughing and like over 800,000 maximal plume area. Even when he coughs in the shirt, right? He's still about 150. That's like, and then you look at like person number 1, they don't even get up over 100, even just coughing unobstructed. Person number 5, person number 3, they're about 150 just unobstructed. But this person is this plume area maximizer, even when they cough in the shirt, right? They're coughing more plume area than most participants.
It's interesting how there's some I'm looking at the mask because that's really the most effective in 3 people. But then in 4, it's 100,000, and then in 5, it's a little higher. I don't know why. Maybe they weren't wearing it. The guy here is wearing a white mask, so it's not even a KN95 probably, right?
Yeah, I'd love to see that too. I mean, this is a pilot study. So what we need to do now is we need to get like a whole bunch of people, and different masks, like, cough into that surgical mask, cough into that N95, cough into that, really the shirt, and what kind of a shirt, right? It matters, right? Am I wearing like a sweater, a sweatshirt? Am I coughing into like a light t-shirt?
Oh, you clearly need a Gucci shirt,
Yeah, the quality of the shirt's going to matter. But I think the big thing is I want to, before I'm like hanging out in like a cold Hitterite, church, I want to make sure I don't have like, participant number 4 hanging out in the same space with me. I'm going to end up getting sick.
So you slept in this church, or you just went there?
No, we stayed there. We stayed there for like several days.
They had rooms?
So what they had converted, this sort of artistic guy who maybe could have had some, better sort of, I guess, architectural training, had converted it, and you didn't want to you definitely weren't going to bend too many back because you had the stairs with like unequal steps that was really super steep. It was almost like you want to rope up to go from the downstairs to upstairs. And then when I showed up, no one had figured out how to turn on the heat because they had those discs where you have to put your hand on the side. I turned on the heat and that really improved, the...
Okay. I'm visualizing you guys sleeping on the pews. That's why I wanted to know.
Yeah. All right. Active vaccination immunity. We've got the article, Hybrid B and T-cell immunity associates with protection against breakthrough infection against severe acute respiratory syndrome, coronavirus 2 vaccination, and Avon longitudinal study of parents and children. ALSPAC participants, published in the Journal of Infectious Disease. So here the scientists investigated cellular and humoral immune responses, so them B and T cell responses to SARS-CoV-2 infection, or vaccination in 300 adult participants. Participants were grouped by those. We have cases, we have controls, and they're going to look for a quantitative correlate for protection against post-vaccination infection in the 8-month period after the study. I probably replaced breakthrough because it was probably driving me crazy. Now, they found that the magnitude of antibody and T cell responses following the second vaccine dose was associated with protection against post-vaccination infection in participants with a history of SARS-CoV-2, but not in infection-naive controls. And then they go ahead and they look a little bit. So they look at these combinations of looking at just anti-spike IgG combined with an anti-nucleocapsid IgG level. The other was a spike-specific T cell. They're doing spot-forming units combined with an anti and pan IgG. And when you create these combinations, you have about 100% specificity for detecting cases without post-vaccination infection. So they concluded that collectively, this hybrid B and T cell immunity offers superior protection after getting this vaccination. But it's interesting. This is people who were infected before, and now you're giving them this protection on top of that.
Yeah, but the T cells are specific for the nucleocapsid protein, right? So you're not going to get that in the vaccine. That's why you need the infection, I presume.
Yeah. I mean, it's interesting, too, because, here we're talking about people who've been infected, like, I don't need to get a vaccine. But no, here, if you get this vaccine, you get this good response, you're going to be protected. All right, I guess I'll mention here this, we talked about this last time about that vaccine-related biological committee meeting where they were trying to decide which updated formula should they offer at all, and they did. They basically said, listen, they asked point blank, if we recommend updating the formula, because some of these people who've had it before, some of the people who've been getting boosted, if we recommend updating the formula, is this going to create a restricted access? Are you only going to approve these updated vaccines for people over 65, and everyone else is going to require a saline placebo-controlled trial? Basically, the answer was, I don't have an answer today. I think a lot of this is still under discussion. So we didn't really get an answer. And there was a lot of data. CDC staffers presented real-world data showing that getting a booster last fall offered added protection, even in people who've been infected and previously vaccinated. Company studies reached the same conclusion, including one by Moderna that compared medical records from about 900,000 people. So I'm going to leave a link into all that data. Also, right after the meeting, they did post on the FDA website, and we have, based on the totality of evidence, FDA has advised the manufacturers of the approved COVID-19 vaccines that to more closely match currently circulating SARS-CoV-2 viruses, the COVID-19 vaccine for use in the United States beginning in fall 2025 should be a monovalent JN1 lineage-based COVID-19 vaccine, preferentially using the LP81 strain.
So we don't know if this is going to require a new placebo-controlled trial, right?
Yeah, we don't know. And that's crazy. They were asked point blank, like, if we just sort of stick with the old, are we good to go? If we make a recommendation, does it change? If we don't change, does it, so we don't know. And the interesting thing is, I went right before we recorded and I looked at the CDC recommendations. They're not changed. They're still what they were. They're still saying, children 6 months to 4 should go get that initial series. Everyone else should go ahead and get at least one booster shot once a year. And though people are higher risk or people over 65, they should get one every 6 months. So that's still what's up right now. So I don't know how that kind of, the tweet, how that all works out. All right, let's move into acute COVID. We've got this article, Do Those Antivirals Work? Oh my gosh, clinical effectiveness of oral antiviral treatment for non-hospitalized high-risk patients with COVID-19 during Omicron JN1 subvariant wave, a U.S.-based propensity-matched COVID study published in the journal Pneumonia. So this real-world study aimed to assess the effectiveness of novel oral antiviral agents in managing COVID-19 among high-risk patients during the Omicron JN1 subvariant wave. Primary outcomes included all-cause ED visits, hospitalizations, death within 30 days, 67,495 high-risk patients identified, 17,852 received oral antiviral agents, 49,643 did not. That's a control group. They did propensity score matching, right? Make sure the two matched. The study group receiving antiviral agents exhibited a significantly lower risk of the primary composite outcome during the 30-day follow-up, hazard ratio of 0.77. So 23% reduction. As far as those secondary outcomes, the study group consistently exhibited a significantly lower risk of all-cause ED visits. So about 22% reduction in ED visits. We had a 14% reduction in folks ending up in the hospital. And mortality, this was huge, right? The 83% reduction in mortality. Now, people can talk about numbers needed to treat, and I think that's reasonable. We talk about mortality, it went from 0.03 was reduced to 0.01. Right, so you could say, oh, but that's like, number needed to treat of 2 per 1,000, and I think that's reasonable. It's fine to talk about numbers needed to treat. It's fine to start talking about, the economics and you wanting to save money and not giving effective treatment to people. But I do think we have to be honest about the fact that these treatments continue to work and the evidence continues to come in. We also have the article, A Systematic Review and Meta-Analysis of the Effectiveness of Remdesivir to treat severe acute respiratory syndrome coronavirus 2 in hospitalized patients, right? So this is a little bit tail of the first week moving into the second. Have the guidelines evolved with the evidence? Published in CID. So here the authors systematically searched Medline, Embase, and Cochrane Library databases for interventional and observational studies examining remdesivir efficacy. A rigorous double reviewer approach was used for source identification, screening, data extraction, and risk of bias assessment. From January 2019 to December 2023, greater than 18,000 sources were screened, 122 unique studies identified. Basically, looking at all this data, remdesivir significantly increased survival in the overall population. Odds ratio 0.69. So 31% reduction across SARS-CoV-2 variants, disease severity levels, supplemental oxygen, no supplemental oxygen, and even rehospitalization risk was significantly reduced. So that's a 28% reduction in rehospitalization. So I know a lot of people talk about saving money. Nothing hurts the hospital's bottom line more than all these readmissions where they go over the line and they stop to get reimbursed. So a really nice graphical abstract. And you can see time to clinical improvement. You can see all the reduction in all-cause mortality across all the different subgroups. All right, and I will just finish off our COVID sort of treatment phase with the article Tocilizumab, Sarilumab, Anakinra in critically ill patients with COVID-19, a randomized control open-label adaptive platform trial published in Thorax. Here they looked at treatment with Tocilizumab, Sarilumab, Anakinra, and no immune modulator in these patients. This is an ongoing adaptive platform trial, 133 sites, 9 countries. Primary outcome was an ordinal score combining in-hospital mortality, days free of organ support. Basically, in critically ill patients with COVID-19, Tocilizumab and Sarilumab were effective, equivalent effectiveness. Anakinra, not effective. So it reminds me of that report in the hospital where they decided that Anakinra didn't seem to be working, but we should keep using it till Monday to use up the supplies we had already paid for. All right, painful. The article, Spike Proteins of Coronaviruses Activate Mast Cells for Degranulation via Stimulating SRC, PI3K, AKT, Calcium, Intracellular Signaling Cascade, published in Virology. So this is this late phase long COVID. Now, in the introduction, they state that substantial evidence supports that mast cells serve as a crucial mediator in the induction of hyperinflammation initiated by SARS-CoV-2, leading to substantial tissue damage across multiple organs in murine and non-human primate models. While previous findings have indicated that the binding of the spike proteins to cellular receptors is sufficient to elicit MC activation, mast cell activation for rapid degranulation, this study is actually looking at intracellular signaling pathways. So really interesting article. There's a lot of, for those of you that enjoy following the signaling cascades, the calcium ions are facilitated by microtubule-dependent granule transport. Ultimately, you end up with the mast cell degranulation. Just to summarize, what's a great study, the study elucidates the mechanism underlying this virus-triggered activation of mast cells and has the potential to aid in the development of mast cell-targeted antiviral therapeutic strategies. Now, from a clinical standpoint, this may help some of us to understand the role of antihistamines and mast cell stabilizing approaches for treating people with both acute and long COVID. So, all right, I will wrap us up here before our emails with no one is safe until everyone is safe. We're in the middle of our Foundation International Medical Relief of Children fundraiser. I hear we've got a group of students about to head to Uganda next month. So I've been in contact with folks there. I think we've got a new manager who's headed to the site. So please help us. We're hoping to get to a maximum donation of $20,000 to help this organization with all the great work it's doing there in Uganda. And I'm hopefully going to try to get over there. So May, June, and July.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Anonymous writes, what is it about Clostridium difficile and the patient's immune system that makes infection in some previously IV antibiotic-treated hospitalized patients recur? Are patients simply reinfected with spores in their environment, likely from the original infection?
Yeah, C. diff is tough. We have a lot of ideas on what's going on. One thing is certain people tend to have recurrent C. diff. So you treat them, they get better, and then they relapse. And it may be that you've never completely got rid of the C. diff. It may be that there's a disruption in the microbiome, right? So these are some of these therapies where they're trying to restore a healthier microbiome, sort of fill that niche. So there continues to be a challenge, and I don't think we fully understand what's going on there.
So Lolly writes, he or she lost their sense of smell when they had COVID for the second time in 2023, recovered, now sick again, and has lost, again, all taste and smell along with the respiratory symptoms. It says it's possibly a flu-like illness. So the question is, does this mean I had some kind of neurological change since COVID? He also has fibromyalgia, and he's concerned about multiple sclerosis. Is there a post-COVID relationship with MS or other neurological diseases and disorders? Since I lost the taste and smell with COVID and now this, am I more prone to losing it every time I get a respiratory virus?
Yeah, so the loss of smell was somewhat unique with SARS-CoV-2, right? Like, initially, people get stuffy nose and they can't smell and they can't taste and they get better. But there really was a lot of interesting work about the sustenacular cells getting involved and actually people having loss of smell that went on for months and months, sort of a part of the long COVID syndrome. So I don't think it necessarily means you're at risk for any respiratory virus, but there may be something about SARS-CoV-2. The other is this link with neurological diseases, disorders. We think with MS, it may take many years from some sort of inciting exposure to actually developing the disease, right? So the Epstein-Barr virus that we've covered, people have suggested there might be a molecular mimicry mechanism, and this is actually involving the nucleocapsid and MS. So a lot of great questions here, and this is why we need to do the research, because we're still trying to sort out a lot of this stuff. So,
Lori writes, please help. We are a large pediatric practice in San Francisco, doing the best we can to stomp out disease. We have won awards for our high vaccine rates, and now we're being told not to do what we love best, vaccinate our kids from a tricky and potentially dangerous virus. We are divided on what we should do. Should we continue to vaccinate, ask parents to sign a waiver, or do we follow, quote, CDC guidance, unquote, and stop offering vaccine? We have always followed CDC guidance in the past, but what even is the CDC now? And is this really their guidance? Also, the recommendations seem vague on who is considered high risk. No one seems to know. Any thoughts on who should be included in this group? Please advise. We need help.
Yeah, no, these are great questions. So let's sort of think through what's going on. So when we're not really sure what happened here. So RFK Jr. sends out this tweet. We haven't seen anything change on the official CDC sites. There's going to be some meetings coming up in June where people actually at the CDC, scientists, clinicians are going to be talking and discussing this. We've also already heard from some of the professional organizations, hopefully we're going to hear more vocally from them, where they basically say, this is the science, this is the guidance. The fact that we have an anti-science, anti-vax political appointee saying this is the guidance and having the political power and maybe even the legal ability to say that, we may have to step back as providers and say, if we can't trust the guidance, then we may have to go somewhere else for the guidance. So really hoping our professional organizations, the ID Society of America, American Academy of Pediatrics, we've already heard from the College of Gynecology that no, this is not in keeping, the science has not changed. These are really just the opinions of an anti-vaxxer.
Lori writes, quick question about eligibility for the vaccine against SARS-CoV-2. With the new guidelines, does that mean people who live with or care for people with comorbidities or with seniors will not be eligible? I hope this is not the case. It seems short-sighted if it is. The way things are going is like watching a train wreck.
Yeah, no, this is really upsetting. I mean, that's one of the things where you live with people who are high risk. Maybe you're a healthcare worker, so you don't want to get it. And we really have like decades of experience where vaccination not only protects you, but it really impacts transmission, right? We use measles as a wonderful example. Someone gets infected with measles, they're not vaccinated, they're going to spread it to 15 to 20 other people. Someone is vaccinated. If they get measles, you probably need 20 of those people before it even goes to one other person. So vaccines have protected others. We have a lot of excellent studies showing similar effect with flu vaccine. We probably need more robust studies with SARS-CoV-2. But yeah, these need to be taken into consideration. I mean, I don't think RFK realizes the complexity of these issues and how many people will be put at risk. So, he can go ahead and tweet that. But I think before the next wave of vaccinations roll out, we're hopefully going to see some level-headed people step in and refine this.
Another quick question. Receiving the vaccine against chickenpox as a child, can it make you susceptible or help prevent shingles as an adult?
Yeah, so this is interesting. So the chickenpox vaccine that we currently give children, this is a replication competent attenuated virus. And in most cases, the thought is this then protects you from being infected with the varicella zoster, the chickenpox virus that'll lay dormant in the nerve and cause shingles. Now, incredibly rarely we see shingles after someone's been chickenpox vaccinated. Now, I don't know if that was someone got chickenpox vaccinated and then they actually got infected with a varicella zoster virus, wild type that wasn't attenuated. But the real thought here is these kids in general are going to be protected against that varicella zoster, protected against shingles, protected against dementia, perhaps.
And Paula writes, I'm an urgent care physician in Wisconsin, so I test a lot of people for COVID, influenza, RSV. Love listening to all the topics included in Microbe TV. Thank you for helping me stay up to date. I would like your opinion on my practice of giving very high-risk patients Paxlovid when they test positive for COVID, even if they may be outside the 5-day window. My arguments for prescribing are as follows. 1, how do we know they didn't have allergies or a different virus 6 or 7 days ago or whenever their symptoms started? 2, wouldn't it still help decrease replication of some of the viruses? It may not decrease your risk of hospitalization or death by 89%, but wouldn't it still decrease it by some percentage? 3, also, might it decrease your risk of long COVID? 4, isn't the potential benefit worth the small cost and side effects of the medication? Those are my thoughts. My partners rarely prescribe it if the patient has had symptoms longer than 5 days. I, of course, want you to back up my reasoning, but please let me know if I should stick to the guidelines of not prescribing if symptoms started more than 5 days prior to being seen.
Yeah, Paula, I'm gonna support your prescribing habits here. So let's just think about the studies, right? So in the studies, they said, okay, we're going to study 5 days. We're going to study getting it within the first 3 days. Then we're actually going to look at people that got it day 4, day 5. They didn't fall off a cliff. People who got it on day 4, people who got it on day 5, they also had really good benefit. Was it 89%? Had it dropped a little bit? Sure, had it dropped a little. But the other thing you bring up too is, I would say the most important and least reliable is the history. So when did the symptoms of this start? Did they have allergies and then they got COVID? Did they have some other thing going on and then they got COVID? So, the medicines, if you go through, look at the drug-drug interactions, in a lot of cases, the cost and the risk of prescribing the medicine is incredibly low. There might be cases where you're getting more of a cost risk, benefit thing there. So you can think a little more about that. But no, in general, I think this makes a lot of sense. And we do prescribe a lot of medicines, not strictly with the package insert. And that's the judgment, hopefully, that we develop in our training.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.